Okay, well, thank you, Pam, for organizing. I think we should get started. What do you think?
Mhm.
And
Yeah, let's go ahead.
We are recording it, so anybody that signed up that missed it will find it on our website, so that'll be good. So welcome, everybody. My name's Eileen Bulger, and I'm a trauma surgeon at the University of Washington in Seattle, and the co-PI of this research project, the National Trauma Research Action Plan, along with Michelle Price, who's here with me today. This is one of a series of webinars that are focused on sharing the results of this project with you and letting you know how you can get access to this data for subsequent analysis. So this project was funded by the U.S. Army Medical Research Command, but the views that we're presenting here are those of the investigators and the authors and not any official Department of Defense views. Next slide. So the goal for today's webinar is I'm going to give you just a brief overview of the center and NTRAP project, so where this is coming from. And today we're focused on 3 of our panels: the Pediatric Trauma panel, the Geriatric Trauma panel, and then our long-term outcomes panel. So we'll hear presentations from the lead investigators in each of those areas. We'll talk at the end a little bit about resources that are available to you as investigators on our website and how you can look at this data across different panels and how to access it. So that's kind of the goal for today. So this project is being run by the Coalition for National Trauma Research. For those of you who are not familiar with CENTER, these are all of the member organizations. So what we've really tried to do is bring the entire trauma community together to speak with one voice and to work on the mission of CENTER, which is to enhance trauma research in the United States by advocating for sustainable research funding that's commensurate with the burden of disease, coordinating research efforts across our professional organizations that span the entire continuum of injury care, and then to enhance the national infrastructure for multi-center investigation. Next slide. And this particular project comes out of a direct recommendation from the 2016 NASM report on zero preventable deaths. Recommendation number 7 in that report called specifically for strengthening trauma research and developing a national trauma research action plan that would then be resourced, coordinated, and provide a joint approach to trauma care research. And so this project was funded directly in response to that recommendation. The aim of the grant has 3 aims. The project has 3 aims. The first was to perform a gap analysis of military and civilian trauma research to identify research priorities, again, spanning that continuum of care. We had a second aim that focused specifically on optimal metrics to assess long-term functional outcomes of injured patients. And the third, to work with regulatory agencies on identifying regulatory barriers and changes that could be made to improve our ability to conduct this type of research. So today what we're talking about are panels from AIM 1, which really focused on this gap analysis. Next slide. AIM 1 project had 11 focus panels, and so we've divided this into a series of webinars so you don't get all 11 in one sitting. And so as I mentioned, we're going to talk about 3 of them today. But these are the focus areas that have done work as part of the NTRAP project and have published papers to outline their results. Next slide. We intentionally have been maximally inclusive, and from the beginning of this project, we reached out to all of the relevant specialty organizations that we could identify that have interest in trauma and burn care, and representatives from each of these organizations were part of this process. And so it really has been a great effort, again, at bringing the whole community together. Next slide. The approach that was taken for this work was using the Delphi method, which is a pretty tried and true method for building consensus around specific topics. It's got a structured methodology. It was all done virtually and somehow managed to pull it off during the pandemic with good participation. And this really gives us a benefit of getting input from a broad array of experts and reaching consensus on what's important. Next slide. The way this worked was for AIM 1 was that each panel on their focus area generated a list of research questions, and then literature was reviewed and provided back to the panelists. And then the panelists went through a series of rounds of rating the priority of those questions where they could see feedback from fellow panelists online to reach the point where we had consensus on the priority of each question. So questions are rated into 3 buckets: low priority, medium priority, and high priority, based on a 9-point Likert scale. And the data provides granular detail around the consensus that was achieved, as well as the exact score to each question. Next slide. And then this was the process, the way it looked online for the participants, so they could see how other panelists had rated that question, and panelists could input a rationale for changing the question. So this led to our strategy around building consensus. Next slide. So these are the publications to date. They're all published in the Journal of Trauma and Acute Care Surgery, and there is a collection of these on the journal's website, so you can click at the top of their website and find them all in one place. As I said, we're going to focus on 3 of these today. Next slide. So I think Dr. Groner we had up first, but I hear he's on his way back from Israel, and I'm not sure he has landed. So perhaps we're going to start, Pam, with Dr. Joseph.
Yes, he's also traveling, but I have his recording. I will pull it up now.
Good afternoon. My name is Bilal Joseph. I'm the panel leader for the Geriatric Trauma NTRAP Action Plan. Thank you for joining. This was the first research agenda ever created for geriatric trauma. For the first time, a multidisciplinary group convened to discuss research. And you can see here that, the real big picture is the conclusion indicated that research is required in many more areas than those mentioned below. And there was a lot of work that really needed to be done. The high priority questions were pain management and frailty guided protocols. However, I can tell you that there was a big variation in what we really needed to do. The panel consisted of over 24 members, consisting of a multidisciplinary team, experts from trauma, geriatrics, anesthesiology, and orthopedics. The panel also included individuals with diverse expertise in all stages of trauma care, ranging from injury prevention to rehabilitation. And the panel really comprised both clinical and non-clinical professionals. You can see the area of expertise and profession distribution here. And we really wanted this because we feel like we pan over a lot more areas with geriatric trauma. We organized the questions using a conceptual framework perspective to ensure that all stages of trauma care were included in our original list of questions. And this panned from injury prevention, triage and transportation, in-hospital care, and you can see care transition and rehabilitation. These are some of the most important or top priority questions for our team in terms of topic and frequency. You can see trauma centers and the use of geriatric specific protocols versus not using them, the use of geriatric protocols and how they impact long-term functional outcomes, regional anesthetic techniques for lower limb orthopedic injuries and how they improved outcomes in geriatric trauma patients, and then how do regional anesthesia versus oral and IV analgesics compare with just oral medications in respect to mortality, pain, delirium, discharge disposition, and functionality of up to 6 months. What really stood out, our focus extended beyond the questions we should ask and encompassed the type of research required. After identifying the need for more important interventional trials, we conducted a secondary analysis and looked at the top 25 questions and evaluated the proposed interventions. You can see the type of research, more interventional clinical trials really were what was needed, and system-based care research. Notably, all panel members emphasized outcomes with a particular trend towards delirium and cognitive function after trauma. Our findings regarding the type of injury and were also intriguing as rib fractures emerge as the top priority. I mean, we deal with this a lot And this implies that more research is necessary in this arena. I think that's one of the things that really stood out, is that this is something we do every single day, caring for these patients. And so the fact that it was a high priority of what stood out really emphasizes the need and urgency for geriatric specific protocols for trauma patients. What are the biggest gaps? Again, gaps in specific types of research design. I think one, interventional clinical research, understanding geriatric specific protocols, and then being consent, complexity of injuries, special conditions, comorbidities, geriatric specific syndromes that really stood out. I mean, we categorized our gaps into two parts: gaps in types of research and gaps in research projects. I think furthermore, while we have a considerable amount of research focusing on clinical outcomes, there's a striking lack of research on patient-reported outcomes as well. And you can see here that, even delirium was a high priority outcome as we looked at our data. When we looked at the biggest gaps, again, regarding the main research topics, we identified several areas that require attention. First, pain management, particularly in rib fractures, really needs focus. Second, frailty is another crucial area that warrants our attention. We recommended that frailty-guided consultations become a standard part of protocol screening, and then interventional trials related to this. And then finally, anticoagulation therapy in older adults has emerged as a significant concern. Fortunately, there's new research coming out in this area, but we still have a lot more to do, not only of how to reverse and treat, but how to extend and restart these medications. What are the most important questions to answer? Really, answering this question is quite challenging. There's so much need, but I believe that once we prioritize research questions, our objectives should be to motivate and involve researchers in these areas. And so how do we encourage researchers to focus on geriatric trauma prioritized topics? I think in older adult trauma patients, questions like what is the effect of frailty-guided consultation on palliative care services, on adherence to evidence-based management guidelines when compared to just attending physician discretion. We must spread the findings of the study. I think that's another area that researchers carry out more, not only carrying out more interventional trials, but actually how to disseminate those. And then the big real question is how to fund more interventional clinical trials in geriatric trauma, because that's a huge question. And there's a lot of organizational work happening to get to a network, if you want to call it that, for this. Some closing gaps in what's next. I really think the NTRAP study has generated a ton of data and is like treasure that needs further explorations. We're just opening Pandora's box. Secondary analysis of the data within our own geriatric trauma panel is our plan. I mean, understanding not only our primary or high level priorities, but also our medium and low priority questions, I think is important. Both clinical and patient reported health outcomes. I think across the panels we find interesting common trends that can't be understood by just one panel, and geriatrics is a great example of this. I suggest to review cognitive health outcomes across all panels, and particularly with like the neurotrauma panel. I think that this secondary cross analysis is critical. I think it's time to review all trauma systems related to these questions and preventive measures to help develop these things. The full manuscript really goes into the detail of this, but our entire infrastructure and prevention treatments is really based on a certain population. And I think our geriatric trauma has really emphasized that we need to spend more time exploring outside of our everyday application of adult trauma guidelines to geriatric trauma patients. Thank you so much for your attention. I look forward to questions and connecting soon. Thanks.
And we'll make the full recording available on the website as well, to make it easier to review. I'm happy to see Dr. Groner has joined us. We're going to switch to the opposite end of the age spectrum now and talk a little bit about the results of the pediatric trauma panel. So welcome, Dr. Groner.
Thanks. Can you hear me okay? Am I audio? Are we good?
Yes, we're good.
Yeah, thank you. Sorry to join the conference late. My brain's still on Tel Aviv time. So, just a couple of slides to go through on the pediatric project. I'd like to thank Pam and the whole team for organizing this. It's probably one of the biggest projects I've ever done. So, anyways, just a couple of things. This is what got published in the Journal of Trauma and Acute Care Surgery. Just looking at the basic methods that I will then go through in more detail on the next slide if we could move ahead. Am I in control of the slide? Do you guys control? Okay, there we go. So the pediatric panel, yeah, we had 36 members. We had, which included pediatric surgeons, pediatricians, trauma researchers, trauma surgeons, burn surgeons, 11% nurses, which I thought was pretty good. Emergency medicine, and we had a couple of epidemiologists, and then a pretty wide area of expertise in terms of hospital-based trauma systems, injury prevention, and pre-hospital EMS systems. So I think it was pretty diverse for us, which was great. The top 3 pediatric trauma questions, based on this like overall rankings. The first question research got was in pediatric trauma patients with hemorrhagic shock. Does TXA administration increase the risk of DVT or thrombotic events compared with standard of care? The next one, in severe pediatric TBI, does the use of ICP monitoring improve survival and long-term functional outcomes when compared with patients treated without ICP monitoring? And the number 3 is, are there clinical criteria that can accurately predict those children who may benefit from decompressive craniotomy with blunt trauma-related closed brain injury without epidural subdural bleed? So just looking at these questions, I mean, kind of the overall theme is that the big research gaps are in questions related to resuscitation, hemorrhagic shock, and questions related to management of traumatic brain injury. And again, I thought this particularly interesting. It was not what I would have predicted. And I think it's the fact that it wasn't what I thought was going to be the topic, I think is probably a good sign. Anyways, next slide. So again, the panel felt that the most important research questions related to traumatic brain injury and hemorrhagic shock. When you looked at phases of care, the highest priority of phase of care was actually the pre-hospital phase, which I thought was interesting. And then overall, looking at there were many questions on mental illness, actually 74, but they weren't considered high priority. So I thought that was just an interesting observation when looking at all the data there, that a lot of mental illness questions, but not say high, they didn't rank as a high priority issue. Next slide. And then the priority ranking of pediatric research questions categorized by specific injuries. Again, I think this is really telling. This is a table that's actually published in the article. And, you know, so on the left sort of grid, it gives a proportion of questions that are high priority. So black is good. And the right, you know, the count of questions. And again, it's just kind of going through the top. So basically every blunt cerebral vascular injury question, here are 3 of them, they're all high priority, which is terrific. And then we're going back a solid organ, you know, going down, you know, kidney injury, there were 5 questions, majority were high priority. And kind of the rest of the solid organ injuries on down. So first blunt cerebral vascular, then kidney, liver, biliary tract, pancreas, spleen. But then when you look at traumatic brain injury, less than half of those questions were high priority, but there were 99 questions. There's a huge number of questions. So I think that's really telling about where the research gaps are. If you look at 99 traumatic brain injury questions and 44 spinal trauma questions, and each of those have a significant proportion that are high priority. And then on down, you know, extremity fractures are the last one that had a significant portion of high priority questions. And then other things which might rank higher, say in the adult world, like things like lung injury and management of rib fractures, which is something that they talk a lot about in the geriatric literature, just didn't rank for the pediatric case. And you can see the rest. So yeah, just again, to summarize, the take-home message is traumatic brain injury, a lot of questions, a lot of high priority, and the same for spinal trauma. Those are the really important research gaps. Next slide. So again, biggest gaps, traumatic brain injury. The management guidelines for severe TBI have evolved significantly over the past decade, and this is somewhat my own opinion, and obviously also what the research panel said. There aren't really good standards. Decompressive craniotomy and ICP monitoring are standard. There's not a lot of good data to support that. I think that's what I would have said, and what the neurosurgeons I work with would have said. The whole group agrees that the results show that further research is needed to prove the efficacy of these therapies. And then the second, on hemorrhagic shock, that TXA is really a standard thing in the adult pre-hospital world, but the panel clearly felt that it's not proven yet in kids. So children are different, and that's an important research gap to identify. So what's next? So again, the most important questions sort of yet to be answered. Does craniotomy improve outcome in severe pediatric TBI? I think that's an unanswered question. ICP monitoring. Does ICP monitoring improve survival or long-term functional outcomes in severe pediatric TBI? And should TXA be administered to children in the pre-hospital setting? And in terms of secondary analysis, I feel like there are still things that could be looked at. Research gaps in child abuse. This is something there were many questions related to child abuse in terms of specific injuries, but overall, I think that's still a gap, an area that could be explored still. And then pre-hospital was the highest priority phase of care, and there are a number of potential secondary analyses on research gaps in pediatric pre-hospital care.
Thank you, Jonathan. Very nice presentation. And I think we're going to hold questions till the end. So we'll go with the next slide presentation, which I think we'll get back up here, is Dr. Herrera Escobar, who led the long-term outcomes panel, also really did the lion's share of the work in aim 2 of this project as well, which is a separate presentation, but he's going to talk about gaps today in research for the long-term outcomes group. So thank you, Juan, for joining us.
Thank you so much, Dr. Bulger, and this is really a privilege to be, be able to share the findings of this project, and then kind of discuss what are the next steps. So, kind of in summary, I think the long-term outcomes panel, I think was one of the panels that there were many gaps that were uncovered, that there were several questions that arose, and I think this speaks to the kind of scarcity of data that we have available in this domain specifically. So there were plenty of research questions that were generated. We defined long-term outcomes as 6 months out from the traumatic injury. So it was very broad, the kind of range of questions that we got. We identified a priori 17 different areas or domains within long-term outcomes that we kind of focus. However, as you'll see later on the data, there were many more that were generating down the process of the Delphi rounds. But in summary, I would say that research on long-term outcomes is scant, that we need to prioritize it as a whole, this domain. But then within that, there are some specific areas that need special attention, and those are mental health, post-discharge health services, and the geriatric population. Next slide, please. So a total of 32 members agreed to participate and were part of this panel. And we have a pretty diverse representation in terms of clinicians involved. So we have trauma surgeons, intensivists, rehab physicians, orthopedic surgeons, as well as decent representation for other kind of stakeholders in this area, such as public health providers, or even trauma researchers, of course, was kind of the vast majority, and burn surgeons as well. And then in terms of area of expertise, so most of the panelists that were part of this area were based have a hospital-based practice, but we also included specialists in injury prevention, in long-term care, and trauma systems, and even pre-hospital. Next slide. So then the top 3 questions that were generated are displayed here. And I think the common thing among these 3 questions is that they talk about interventions. And I think that was a common pattern along the different questions that we found in this panel, is that although there is an important gap in kind of understanding better long-term outcomes for trauma patients, the field is kind of moving now towards identifying what type of interventions could be implemented so that we can address and improve long-term outcomes for this population. So it was very, very interesting to see that the top rated questions were along these lines. The first one in particular speaks to the effectiveness of early intervention or providing mental health services and in the rates of PTSD for patients in the long term. The second question kind of speaks about the effectiveness of trauma survivorship clinics or having a patient navigator to improve long-term outcomes in the long term. We have seen kind of this program starting to become very popular in trauma centers in the country. So this question was very highly ranked to see whether these programs are really effective in improving the long-term recovery. And then the third question was about patients, geriatric population, and see whether home PT or occupational therapy or even home health services kind of have a very similar effect on inpatient rehabilitation for geriatric trauma patients, but at a much lower cost. Next slide, please. So what stood out? I think on many things, but kind of in summary, I would say the first thing that really don't want to say surprised me, but I think it was very, very interesting was that none of the questions was deemed as low priority. And I was expecting a very high number of questions as high or medium, but actually seeing that actually no one was rated low priority was actually quite impressive. And also that most of the health domains, and what I mean by health domains, and I refer to physical, mental, social, and cognitive, they were pretty well represented in the research question, and with a pretty even number of questions across these domains. As you can see in the graph below, there was only kind of one domain that really kind of highlighted among the others, which was the functional recovery. But all the others were pretty much the same in terms of the number of questions that were generated. However, in terms of the high priority questions that were generated within these health domains, the mental health had a particularly higher proportion of high priority questions that were generated. So that's also kind of an important thing to keep in mind. Next slide, please. So the biggest gaps that were uncovered, I think, were primarily on the mental health domain, and specifically on mental health interventions. And so this is something that researchers and people involved and panelists really come to an agreement, and it is that that intersection between kind of interventions and the mental health outcomes of patients are really a priority area. But also the role of social services in long-term outcomes, and what I refer by that is the role of peer support in the recovery for trauma patients, or having programs that include peer support, or programs that provide a comprehensive kind of intervention to address social determinants of health or other components of recovery. And such examples of that are the trauma survivorship clinics that I mentioned earlier, but also the violence intervention programs, the hospital-based violence intervention programs. And then the third domain was geriatric trauma. I think within the demographics, I think the geriatric population was the one that was highlighted the most in the long-term outcomes population. And specifically, there were a lot of kind of shared interest with other specific areas, such as the effect of rehabilitation services, the effect of mental health services, the effect of any other sort of intervention within this specific population. Next slide. So I think kind of to reiterate, I think the really the most important next step in terms of this research agenda, I think it is addressing the questions that are related to interventions to improve long-term outcomes in trauma patients. I think this is something that was a common denominator and something that kind of we are starting to have some research in the area, but that most researchers agree that there's still a huge gap that needs to be covered, and specifically, like I mentioned before, and the mental health would be kind of a first place to start. Next slide, please. So here in this table, we kind of see that, which is the wide variety of areas that were kind of explored by the different questions that were generated in this panel. And one of the things that was interesting is that the proportion or the total number of questions that were generated within each of these areas was pretty similar across the board. However, the proportion of high priority questions within these domains really differed depending on the specific area. And like I said, mental health, social services, and geriatric trauma were the top three within this group. However, it's also kind of refreshing to see that there is kind of homogeneous interest across the different health domains, as opposed to what we probably would have found 20, 30, 40 years ago if we have conducted this, which would probably be a more kind of focus on the physical recovery, but maybe not as much on the mental health or social health of this population. Next slide, please. So in terms of ideas for a secondary analysis, I think there are plenty of opportunities. As we heard from Dr. Joseph in his presentation, there is a ton of intersection in the research we're doing with many panels, and he explicitly mentioned the high proportion of questions that were generated on the long-term outcomes area. In fact, actually, the number one question was kind of partially referring to long-term outcomes in geriatric patients. So that's kind of an immediate next step in terms of secondary data analysis would be to establish some kind of or starting merging some of these internal databases that we have available as part of this aim of NTRAP, and the ones that makes more sense. In fact, we for this panel already started doing that with the burn panel, and I think that could potentially bring up more insights into the specific priorities of kind of that combination, which I think would be very interesting and kind of would help us kind of make priorities within priorities, which is something that it's also important given limited resources and time we have. So that's one, and then the second, which is more specifically for a long-term outcomes panel, I think has to do with the priorities within the health domains. I mean, I think this was kind of an initial approach to defining what's the most relevant for long-term outcomes, but that's a big universe, and within each of the health domains, I think there's an important there's still some sort of important kind of prioritization that needs to be done, and that's something that could be achieved separately, but using NTRAP data as a start line and kind of establishing that those priorities. So I think that's all what I have to share today, but I'm happy to take any questions. And again, thank you so much for the opportunity to present this, and of course to the NTRAP group, the leadership team, and it was a tremendous amount of work that we did for the past few years, but definitely we're seeing now the results, and it's very exciting.
Thank you, Juan, for that excellent presentation. Let me pause here just to see if there are any questions for Dr. Herrera Escobar, Dr. Groner, before I give you a strategy as to how to get a hold of this data. I'm not seeing anything in the chat, so I'm going to move along, but if you think of something, feel free to drop it in the chat. I'm happy to relay it also to the speakers. Our goal is to make this very available to you for several reasons. One, I think one of the greatest strengths of this data is if you're writing a grant in one of these areas and you can point in the significance section of the grant to the fact that this was a high priority issue identified in this process, I think that lends a lot of support for your grant application. So that's one area where, if using this data could be very productive. But we think there's also opportunity to use this data in driving collaborative research projects, multi-institutional trials among our organizations and things like that. So other things to think about. Where you go is you go to the center website under the research tab. There's a QR code here that will take you there as well. And that's where you'll find all of the NTRAP resources. It has an overview of the project, an overview of the methodology, and helps you get links to the papers. Next slide. So what you'll find there, again, a brief overview of the project. We are putting together an executive summary, which should be up there very soon. You can sign up for these webinars. You will also be able to view these webinars on that site as well that are recorded. There's a description of each aim. There's a description of the people who are on the panels, the expert panels, so you know who participated. We have literature reviews that were done for each Delphi panel that are also available up there. And then importantly, one of the things that took a lot of time in this project, but I think was critically important, is that we created a taxonomy, or basically a set of consistent keywords across a number of domains that every single question was tagged with, so that allows searching across panels. So if you want to search for particular injury patterns, for example, rib fractures, and you want to see what every panel had to say about rib fractures, that could be all pulled together into one analysis by searching through this taxonomy. So that's just an example of that. But we think there's a lot of opportunity for secondary analysis using that strategy for whatever it is that you're particularly interested in. So there is a data request form on the website that you can fill out. We'll contact you and work with you to get you whatever data you need for secondary analysis. Next slide. So these are the just a small sample of the taxonomy. The full taxonomy is listed there, but we have broken down and tagged every single question with the population that it's most relevant to, the phase of care. So if you just wanted to look at all of the pre-hospital questions, again, we had a pre-hospital specific panel, but pre-hospital questions came up in all the panels. So you might want to search across that. Injury patterns, whether you want to look at blunt, penetrating, blast injury, and then specific injury types, and then looking at specific intervention strategies, clinical outcomes. So maybe you want to look at all the questions that looked at pain as an outcome or clinical state. Patient reported outcomes, as was just alluded to, and then the type of research that was described. Next slide. So this is the data request form. It's pretty straightforward. You give us a project of your summary, a summary of your project, and then whatever data you need, and then we'll work with you, because we obviously, if we get duplicate requests, we try to put investigators together to work together on specific projects, and we have a publications committee that can also help in that process. Next slide. The data is embargoed for 1 year, beginning with the pre-publication for each panel, but there are so many panelists that are involved in these projects that any panel leader, any panelist can have access to the data right now. And so if you're not one of the panelists, and we had like 400, 500 people that were panelists, you can find one on the website that you know, I'm sure, and they can also work with you to get the data sooner if you need to. It takes us about a month, usually, to process a data request. And then we ask you to sign a data use certification agreement and comply with our publications policy. Next slide. So I'm going to stop there, see if there are any additional questions about the project, about accessing the data, or anything else. And if not, we're going to wrap it up.
I have a comment.
Yes,
Okay.
Dr. Price, yes.
Hi, everybody. I thought it might be helpful to explain that basically where we are in this project is that we've published all but one of the primary manuscripts. Actually, one just came out in JTACS today on trauma systems in its final form. And so now, what we're looking for are all these untapped opportunities where people can do what we refer to as secondary analysis. There's one paper that has been done on secondary analysis. It came out of an NIH-funded VTE prophylaxis research conference that we put on last May. And the leaders of that conference decided to look at the VTE questions across all of the AIM-1 panels. That's just been submitted for publication. But when the authors, the panel leaders talk about, opportunities for secondary analyses, these are things that, for the most part, we haven't been approached by anyone to do those additional analyses. We've had about 12 investigators request data so far. And like Dr. Bulger said, we turn those around in about a month and get them the data unless the data are embargoed, but it really hasn't been an issue because like she said, the people who've asked for the data thus far have been panel members or they partnered with panel members. We have had one situation where two people were thinking about looking at the same data, and so we did put them together. They had very similar questions that they were trying to answer. And the data themselves are super easy to use. These are just basic Excel files. And you can use taxonomy like Dr. Bulger was talking about, which is really helpful for quick analyses across panels. But you can also do just word searches. Maybe there's a particular word that's not in a taxonomy tag, but you can search for that word because these are just, simple Excel files. And so far, the materials that we've provided to the researchers have been sufficient. They haven't had trouble digging into the data or using the files as far as I know. We are definitely interested in hearing your ideas and would love to see these data used multiple times. And like Dr. Bulger said, if for nothing else, to justify the significance of a problem when you're writing a grant application or in the background section of a paper.
Thanks, Michelle. All right, I'm not seeing any other questions. I want to thank our speakers for today. Dr. Grona, I hope you get some rest after your travel. We look forward to continuing this conversation in the next webinar. Pam, when is the next webinar scheduled for?
The next webinar is May 25th.
All right, so look out for that. And I hope you have a lovely day. Thank you so much.
Thanks, everybody.
Right.
Thanks, everyone.
Bye.